Okay, so I'm gonna give you key questions, and I want you to tell me what do you think of these questions, okay?
Okay.
Mostly on the physical exam, that's what I'm gonna focus. I want you to know the question from the minimum amount of information. So, okay, so 17-year-old boy who on examination you found moderate pustular acne with erythema but no scarring, and he's already taking topical retinoin and benzoyl peroxide. So what is the best next step in management for this patient? And those medications didn't work, so what do you do after that?
What is he taking?
Retinoin.
Sure. Oh, he's already taking that?
Mm.
And it's still not working? Well, he has really bad acne.
Yeah, topical, because taking topical retinoin.
Yeah.
Yeah, so the trick
Oh.
for that is that we add topical antibiotic, topical erythromycin patient. So there are three types of acne. There is comedonal acne, inflammatory, and nodular cystic.
Yeah.
The comedonal, you will find only comedones on the forehead, nose, and chin.
How do
And
they decide that? The comedonal one.
they tell you open or closed comedone, that's what they say. They tell you without inflammation or pustules or nodules. Yeah. So this one you treat with topical tretinoin, but then when it progresses with pustule and erythema, this is inflammatory, we add topical antibiotic. If it didn't work, then we add oral antibiotic. And then if it progressed to scarring, then we add oral isotretinoin. That's about the antibiotic management of acne, period. Okay, we're gonna go to the next one. Okay, on physical exam, you find hyperpigmented velvety lesions are found on the axilla and the groin, and you found darkened and thickening of the skin over the neck and the groin, and sometimes it's itchy. What is this associated with? What is your diagnosis?
That's insulin resistance?
Yeah, excellent. This is insulin resistant associated with polycystic ovary syndrome. We have association acanthosis nigricans associated with insulin resistance and GI malignancy, skin tag associated with insulin resistance, pregnancy, Crohn's disease, porphyria cutaneous tarda associated with hepatitis C, dermatitis herpetiformis with celiac, psoriasis, severe psoriasis, and recurrent herpes zoster, disseminated molluscum contagiosum associated with HIV, seborrheic dermatitis associated with HIV and Parkinson's disease, and explosive onset of seborrheic keratosis associated with GI malignancy, pyoderma gangrenosum associated with inflammatory bowel disease. Okay, so those are the associations. Period. Okay, patient taking warfarin and acetaminophen and taking green tea and spinach. What is the cause of which of these interact with warfarin, increases warfarin?
Increases warfarin is the azole.
Acetaminophen, yeah, right. Yeah.
Yeah, like the
Yeah.
one of those.
So there are the things that increases warfarin level is that acetaminophen, non-steroidal anti-inflammatory drug, antibiotic, antifungals, metronidazole,
Yeah, yeah,
amiodarone,
yeah.
cimetidine, cranberry juice, ginkgo biloba, vitamin E, omeprazole, thyroid hormone, SSRI. The one that decreases warfarin level, carbamazepine, ginseng, green vegetables, spinach, oral contraceptive pill, phenobarbital, rifampin, and St. John wort. Period. So those are the warfarin stuff, okay? Okay?
Yes.
Now get ready for this. This is a good one. Okay, so 67-year-old man, cardiac index 2.3, so it's decreased. The normal is 2.8 to 4. And pulmonary capillary wedge pressure 26 increased. Systemic vascular resistance is 2000. and he's having hypotension, tachycardia, and he's having cardiogenic shock called CLAMI, blood pressure 70/40, pulse is 112. What is your diagnosis in this patient? Told you, Lana.
So you said he's having cardiogenic shock.
Exactly, yeah. So that's the diagnosis because of the pulmonary capillary wedge pressure increase. That's called cardiogenic shock. So there are different types of shock. So for normal right atrial pressure 4, pulmonary capillary wedge pressure 9, cardiac index 2.8, which is almost 3, systemic vascular resistance mean of 1000, mixed venous oxygen saturation is 60% to 80%. So in hypovolemic shock, all
Wait,
of
I'm
them
sorry.
decrease, huh?
The cardiac index is what?
It's around 2.8 to 4.
Okay, and then after that, I didn't hear anything. You cut out.
Yeah, the systemic vascular resistance, and that's what I'm gonna compare, like the difference between those variables, how to diagnose shock. Okay.
Okay.
Yeah, so this is important differential. So this is one on. So for hypovolemic shock, the right atrial pressure will decrease because you're losing fluid. So the right atrial pressure decrease, pulmonary capillary wedge pressure decrease, cardiac index decrease, and the mixed venous oxygen saturation decrease. The only one that increases is the systemic vascular resistance due to sympathetic reflex, sympathetic activation. While in cardiogenic shock, right atrial pressure increase, pulmonary capillary wedge pressure increase. Why? Because it's not pumping, the heart is not pumping. Systemic vascular resistance will increase too. The cardiac index will decrease significantly, and mixed venous oxygen saturation decrease too. That's cardiogenic shock. Septic shock, right atrial pressure is not affected, pulmonary capillary wedge pressure is not affected. They could be normal or decreased. The main thing that will be affected is systemic vascular resistance will decrease. The only shock that has decreased systemic vascular resistance is septic shock, because the endothelin attaches to the vascular system and causes dilation. And the cardiac index will increase, and mixed venous oxygen saturation will increase too. Okay, that's it. Period. So this is a comparison of different types of shock. Do you get the idea?
Yeah, can we go over cardiogenic again?
Okay, the cardiogenic shock have increased right atrial pressure, increased pulmonary capillary wedge pressure, decreased cardiac index, increased systemic vascular resistance.
Okay.
Yeah. Makes sense, right?
Mhm.
Alright, so I'm gonna give you another case. You ready? Okay. So patient have pitting edema, point of maximal impulse is displaced to the left, holosystolic murmur, bilateral crackles. Sodium is 128, potassium is 5. What is the diagnosis and what indicates severe heart failure?
CHF is the diagnosis.
Yeah.
I think like mitral regurg. And then what was the other question? What determines severity?
Hmm.
Damn, I feel like I know this.
Okay, so what determines severity in this patient? Hyponatremia, because 128. Other things that determine severity, there are clinical manifestation, which is higher NIHA classification, resting tachycardia, presence of S3, increased JVP, low blood pressure, moderate to severe mitral regurg, low maximal oxygen consumption, peak VO2. Lab results, hyponatremia, elevated proBNP, renal insufficiency, and we have the EKG finding when you have a QRS duration more than 120 milliseconds, left bundle branch block pattern, that indicates severity, and echo finding also when you have severe left ventricular dysfunction and you have diastolic dysfunction, reduced right ventricular function, pulmonary hypertension. All of that indicates severe heart failure, because obviously like these things happen when you're pretty bad, heart is not working at all. Other things that indicate severity is that anemia, when you have anemia, atrial fibrillation, and diabetes mellitus. This indicates severity. Period. Okay?
Yeah.
Okay, so those are the okay, now I'm going to give you a good trick for a question. Okay. So 20-year-old female who present with intermittent chest pain that's sharp located to the left of the sternum and lasting 5 to 10 seconds. Cardiac auscultation, here's the key. All of what I said is not that great of a key, but this one will give you. Systolic murmur at the apex that shorten with squatting. What is the diagnosis?
Hold on 1 second. So systolic murmur that shortens with squatting. Is that MVP?
Excellent, yeah. This is called mitral valve prolapse, yeah. So remember this. It's like a fighter. Fighter when squat or hand grip. Imagine you squat and hand grip at the same time. You're low, right? So this decrease the murmur. But then when you stand up and do standing and Valsalva increases the murmur, okay? So imagine, yeah, when you sit, this is low. When you stand, this is high. So this is how you remember. And while you're sitting, hand grip, just to have a visual representation. So when you sit and squat, decrease the murmur. And when you stand and you say, like someone playing karate or something, this increases the murmur.
Okay.
For hypertrophic cardiomyopathy and mitral valve prolapse, for both of these conditions, squatting, hand grip, decreases murmur. Valsalva and standing increases the murmur. Just remember, that's only for hypertrophic cardiomyopathy and mitral valve prolapse. Everything else is the opposite. So just remember these two because those are the different ones, and then the other ones are the other ones, okay? So I'm going to give you another case. So what medication to withhold prior to cardiac stress testing?
Say that again?
What medication do I withhold before cardiac stress testing?
Do I have options?
Okay, so here are the medications. I'll tell you about them. The medications that the hold for 48 hours is the beta blocker, calcium channel blocker, and nitrates, because those interfere with the contractility, so I don't want them to be in the stress test. Hold for 48 hours prior to vasodilatory stress testing, dipyridamole. Hold for 12 hours prior to vasodilatory testing is caffeine and drinks. There was one of the NBME question, they say which one, and the only one they said is caffeine. That was very tricky. I remember I did that wrong. And the one you continue, angiotensin converting enzyme inhibitor, angiotensin receptor blocker, digoxin, statin, diuretics. Okay?
Digoxin, statin, and what else?
Diuretics.
Thyroid.
Okay, new case. 45-year-old female present with nausea, fever, upper abdominal discomfort.
That's it?
Okay. The patient describes severe tinnitus and vertigo. What's diagnosis and what do you expect her ABG? Period.
She has epigastric tenderness and vertigo. That's it?
Tinnitus.
Tinnitus and vertigo. Does she have Meniere disease?
She overdosed. She's overdosed on medication too. Now what do you think?
Wait. Oh, aspirin.
Yeah, excellent. This is aspirin intoxication. So what ABG finding you suspect they will have metabolic acidosis with respiratory alkalosis. So the HCO3 will be decreased to around 12 due to metabolic acidosis, and the PaCO2 will be decreased too because of the hyperventilation, respiratory alkalosis. So it's a very unique combination. So the pH will be normal. Period.
Wait, so pH is normal and bicarb is low and CO2 is low?
Yep.
Okay.
Okay, 60-year-old woman present with lethargy and confusion and lost 10 pounds. Serum osmolarity is 250. Urine osmolarity is 500. Urine Na is 45. What is the best next step? I can give you also that she has a mass on her chest X-ray. So what's best next step?
So this is probably a tumor causing all of this. So imaging?
So she has sodium is 117. So this is, so if we were, let's study this case. So the first evaluation of hyponatremia, you look at the serum osmolarity. Is it more than 20 to 90? If it's more than that, then it's either hyperglycemia or renal failure. But if it is less than that, then we look at the urine osmolarity. If it's less than 100, then this is a primary polydipsia or beer drinker potomania. But if it's more than 100, then you look at the urine sodium. So in this patient, the serum osmolarity was decreased, was 250, and the urine osmolarity was 500. So now we look at the urine sodium. If it's less than 225, then this is either volume depletion, CHF, or cirrhosis. If it's more than 25, like in this patient, 45, then it's SIDH or adrenal insufficiency or hypothyroidism. Since this patient had lung tumor, so most likely SIDH. So now the management of SIDH, if the patient is asymptomatic or mild symptoms, forgetfulness and stable gait, we do fluid restriction, oral salt tablet, and loop diuretic if the urine osmolarity more than 2 times serum osmolarity. Like in this patient, serum osmolarity 250, urine osmolarity 500. But if there is moderate symptoms, this patient had like confusion, lethargy, this patient had moderate symptoms. So you'd give hypertonic saline in the first 3 to 4 hours to increase sodium more than 120. And later treatment is the same as mild, which is fluid restriction, salt tablet, loop diuretic. But if they have severe symptoms like seizure, inability to communicate, or coma, then you give him bolus of hypertonic saline until symptom resolution, and you give him vasopressin receptor antagonist, which is convaltan. Okay, so those are the management of syndrome of inappropriate antithyroid hormone secretions. By the way, again, those cases that I'm giving you are the trickiest cases, like the tricky ones that I collected. Okay. So those are the how workup of hyponatremia and the management. Period. So how's your studying?
It's not bad. It's actually pretty good. Monday through Friday, it's good. The weekends are a little eh.
I see.
That's why the weekend I was asking if we can just do it in the morning so I can make sure that I have it done.
Yeah, I tried to do it in the morning. Yeah. I'm gonna. What do you think? I'm gonna create like a course like this. What do you think?
Yeah, it's good. It's because at the end of the day, it's hard to do UWorld by yourself to understand because there's so much information. So it's like, what do I need to know?
Yeah, exactly. Yeah, that's I wished someone did it for me, so that's why I'm gonna do it for the people.
Yeah.
Okay, so let's go ahead. Okay, so now I'm gonna give you another case. Okay, so patient present with PaCO2 is 25, pH 7.42, PaO2 100, bicarbonate 14. What is the diagnosis?
Oh, this is acid base. So pH you said is 7.42.
Just focus on two, PaCO2 25 and bicarbonate 14. That's all what you need to know.
25 and 14. So CO2 is low. So that's acid. All right.
Mm.
Some sort of acidosis.
Yeah, so the
No.
bicarbonate is low, this is
Yeah.
metabolic acidosis, and the PaCO2 is low, this is respiratory alkalosis.
Yeah.
So this is aspirin intoxication.
Okay.
So those are the acid-base disturbance. If there is metabolic acidosis, then the PaCO2 equal 1.5 by HCO3 plus 8 plus minus 2. This is Winter family. But in case metabolic alkalosis, then PaCO2 will increase by 0.7 for every 1 MEq rise in HCO3. But if it was respiratory acidosis, then the HCO3 will increase by 1 for every 10 mmHg rise in arterial PaCO2. But if it was acute respiratory alkalosis, then there was decrease in HCO3 by 2 MEq for every 10 mmHg decrease in arterial PaCO2. If you got lost, don't worry about it. Just remember, in acidosis, HCO3 increase for every increase in PaCO2. In respiratory acidosis, and respiratory alkalosis, HCO3 decrease for every decrease in PaCO2. And in metabolic alkalosis, the PaCO2 increase for every increase in HCO3. And in metabolic acidosis, that's what you need to remember, Winter formula, PaCO2 equal 1.5 by HCO3 plus 8 plus minus 2. Okay, that's all what you need to know, period. Okay, got it?
Kind of.
Yeah, it needs like yeah, so this is Winter formula equation.
Mm.
Okay, a 32-year-old woman brought to the emergency department due to weakness and tingling in her extremities. Potassium is 2.9, HCO3 is 37, so that's big. pH is 7.56. Urine electrolytes, chloride is 7, sodium 16. What is the most likely cause of this patient condition?
Tingling. Something diabetes, right?
So this is how you work up this case. The most important thing you look at is the HCO3 and pH. If the pH more than 7.4, HCO3 more than 24, this is metabolic alkalosis, like in this patient. Okay. So after you find metabolic alkalosis, what do you look for next? That's a very important question. You look at urine chloride. Okay? If the urine chloride below 20, low urine chloride, then this is either vomiting, nasogastric aspiration, or prior diuretic use. And this is called saline responsive. Huh?
You look at the urine chloride, and if it's under 20,
Yeah,
then what is it?
this is vomiting. nasogastric aspiration. Like you're losing acid from your stomach.
Okay, vomit, aspiration, and what else?
Prior diuretic use.
Okay.
Okay. But if the urine chloride is high, then you look at the blood pressure. If she is hypervolemic, then this is excess mineral or corticoid activity, either primary hyperaldosteronism, Cushing disease, ectopic ACTH production, or hypovolemic, euvolemic. If there is hypovolemia or euvolemia, then in this case, either diuretic use right now, current, or Bartter-Gitelman syndrome. Period. Okay, you got the idea?
So, urine chloride, if it's over 20, you look at blood pressure or volume status?
Yeah, volume status reflect the blood pressure. They're the same. Yeah. If their blood pressure low, that's mean hypovolemic.
Yeah.
Yeah. If the blood pressure is high, then that's hypervolemic. Okay, so this is and like remember, if they're vomiting or using diuretic, they respond to fluid. When you give them fluid, this will correct the metabolic alkalosis. But if they have Cushing syndrome or Gitelman syndrome, this is saline unresponsive. This is more difficult management. Okay, so that's the metabolic alkalosis case, period. Okay. 59 women with the lower GI bleeding, her ABG pH 7.15, PaO2 80, PaCO2 60. What contribute to her lethargy?
Acidosis.
Yeah, exactly. This is acidosis due to hypoventilation because PaCO2 60, that indicate hypoventilation. Period. Okay, let's go to this one. Okay, 36-year-old male who present with confusion, nausea, and decreased arousal. pH is 7.2. PaCO2 is 28. Bicarbonate is 12. BU1, you don't need that. Just bicarbonate and PaCO2. Okay, what's your diagnosis? What metabolic status?
So he's definitely acidotic because respiratory acidosis. Oh wait, hold on. Yeah, respiratory acidosis.
Why?
He said 7.2 is pH and bicarb is low. So is that not respiratory acidosis?
So this patient bicarb is low, reflect metabolic acidosis, and they have a compensation. So if it was respiratory acidosis, the PaCO2, you will find it high, like the previous question. So this patient is anion gap metabolic acidosis because the bicarbonate is low, 12, and the PaCO2 is 28. So they're trying to compensate doing hyperventilation, and the pH is 7.21. So this is anion gap metabolic acidosis, period. Okay? And the anion gap, how do you calculate? Is the Na minus HCO3 plus chloride, period. I love this question, it's very tricky. And the causes of acidosis are lactate, ketoacidosis, methanol, glycolic acid, oxalic acid poisoning, like ketone glycol poisoning, salicylate poisoning, uremia, impaired excretion of H, like in renal tubular acidosis. Period. Oh, this one tricky one. Cool. Okay. So patient have 20-year-old man with calcium is 11, parathyroid hormone level is 65, urine calcium over creatinine clearance less than 0.01. Which of the following condition is most consistent with this patient finding?
You said urine calcium is what? Under 0.0 something?
Yeah.
That's the familial hypocalciuria, FHH.
Excellent. This is familial hypocalciuric hypercalcemia. The key to differentiate it from hyperparathyroidism is that they have the calcium to creatinine ratio more than 0.02 in primary hyperparathyroidism, less than 0.01. This is familial hypocalciuric hypercalcemia. Period.
Mhm.
You see how we can know the question from very few information.
Yeah. It's all about like picking out that information because when you read the whole video, it's so
Exactly.
confusing.
Clue. Okay. 45-year-old man presented to the emergency room with fatigue and poor appetite and weight gain. Okay. Blood pressure is 200. Physical examination shows anasarca, distended JVD while sitting upright. Lung auscultation shows crackles. Urinalysis shows 1 plus protein, no nitrate, trace leukocyte esterase, more than 50 red blood cells, and red blood cell casts. That's a big. And occasional neutrophils. So what is your diagnosis of the edema? What is the cause of that?
RBC cast. So, hold on. RBC cast? Can you say that again?
Yeah, so that's the clue for this question. Whenever you see RBC casts,
Yeah, it's something with the
this is
glomerulus, right?
primary glomerular damage.
Yeah.
Okay, period. That's it.
Oh, I thought you were asking for like the specific actual disease.
Yeah, that's a disease, glomerular damage. Yeah. Yeah, so there are the causes of peripheral edema. There's increased capillary hydrostatic pressure, like heart failure, cirrhosis, renal sodium retention, and there is decreased capillary oncotic pressure, like protein loss, nephrotic syndrome, protein losing enteropathy, decreased albumin synthesis, cirrhosis, malnutrition, or there is something in increased capillary permeability, which is burn, trauma, sepsis, allergic reaction, malignant ascites, or there's lymphatic obstruction, increased interstitial oncotic pressure, which is malignant ascites, hypothyroidism, lymph node dissection. Those causes lymphatic obstruction. Okay, period. Get the idea?
Yes. Hold on 1 second. My mom's calling me. 1 second.
Take your time.
Hey, Moali,
Yeah.
do you mind if we pick up tomorrow? My mom's not feeling well.
Oh, okay.
We'll continue in the morning.
Okay, no problem.
I'm sorry.
No problem. That's okay.
Thank you.
You're welcome. Bye.